For me to present this topic in front of my senior professor, the BS competition for every year, and he is a real mentor. And it's really a great pleasure, sir. Thank you very much for giving me an opportunity. And also I would like to thank Team Juventus for giving an opportunity to present in front of all the esteemed founders and friends over here. And today we are here together. Already we have been discussing the basics in obesity after a good talk by Dr. Arun. And we will be taking on next with what is newer to think about the MASH and obesity. What are the various drugs to be considered? First of all, nowadays obesity is not only a simple weight gain related entity. It is a problem which is going to affect your liver, your renal system, your cardiovascular system, your metabolic parameters, your bone parameters, respiratory, sleep apnea, multiple other complications the patient is going to develop if the patient is going to develop obesity. So what is the primary thing we are going to address? We need to tackle any patient who is going to land up with evidence of metabolic syndrome. Initially, the terminology NAFLD was there, non-alcoholic fatty liver disease. Now it has been completely replaced by a terminology what is called as metabolic associated steatotic liver disease. Why such things happen? Because even though if the patient consumes alcohol to minimal extent, the patient may be considered the background because most of the metabolic parameters will be involved in this kind of scenario. That's why instead of considering as non-alcoholic, they will be taking the terminology as metabolic associated steatotic. So what is that? If the patient is having 5 major parameters of your metabolic syndrome, like your BMI, along with evidence of your dyslipidemia, your PGL to the higher side, along with your HDL tends to the lower side, and your plasma glucose and hypertension sets, with base circumference if it is going to be more than 90, if it is going to be more than 80 in females, which means the patient, there is possibility for them to go for metabolic syndrome. If any of this point has been addressed, we need to be very cautious. We need to look into multiple other presentations. And what is there to consider about obesity? Once the BMI, if it is going to be more than 25, if it is going to be more than 30, 35, and 40, which considered in the range of supermorbid obesity, based upon that, you are going to think about various molecules to target this kind of patient. And in our scenario, there are various new molecules. Initially, obesity, if you are going to look, initially, if you are once a patient is going to land with evidence of fatty liver obesity, nowadays the molecules not only is there to tackle your obesity, your diabetes alone, there are some molecules definitely being considered once the patient is going to land with evidence of your steatohepatitis. Before taking on, first thing, any obese patient, more than 80% of the population will be having fatty liver. Once the patient is going to land up with fatty liver, the next problem will be your steatohepatitis. Steatohepatitis, which means the inflammation and ballooning degeneration, all these things is going to take off with the enzymatic elevation, all this process. And if this thing is not going to get controlled, the patient is going to land up with evidence of cirrhosis, and next to that, the peripheral carcinoma, what's called as hepatocellular carcinoma, is going to take on, and your decompensation and other events is going to set in. So before that, if the patient is going to land up with evidence of this obesity, and how are you going to prevent the progression of the patient to land up from evidence of steatotic liver to prevent the progression to of MASH to occur? The first molecule what they are going to consider in various trials, this video paradigm is being considered is semaglutide being tried. Why this semaglutide? It has been widely like change. So what is the basic thing? So usually when you are the therapeutic gap, ideally if you are going to maintain a good diet source, you can able to establish only 10% of the weight loss. But how far it is going to be significantly following? Around 3 hours. So I mean at least around 30 to 45 minutes per day you need to do exercise to improve that. So how far you are going to establish it? So still a strong therapeutic gap is still being established. Your diet modification, your lifestyle modification, exercising, and all those things doesn't mean that the patient is going to have significant improvement in your liver pathology. That is why even if your caloric weight loss and this weight gain is still a contributory factor, which means your metabolism, your hunger preponderant factors, apart from that your hormonal factors and your caloric activation along with your various exercise and routines, that we having a strong lifestyle growth is still playing in this contributory factor to look for evidence of progression to MASH. And starting from basic therapy like your metformin, your pioglitazone, vitamin D, there are so many molecules being tried, and for weight loss. So various molecules are being addressed for this weight loss along with evidence to control MASH. In that, the stronger molecule what we can consider is the initial phase, the orlistat and other molecules are not being tried, but that doesn't show any major response, except for your dyslipidemia and other things which needs to be getting improved to some extent. But Nowadays, the game changer is mainly in either the single agonists or double agonists or triple agonists. So what is it? The main thing is GLP-1A receptor agonist. So one molecule is called as semaglutide. Next to that, the GLP-1A receptor agonist along with your glucose-dependent insulin-dependent polypeptide like GLP as well as GLP agonist. These two molecules like to trace the chemical calcium. Apart from that, even available in the field as of now, and we have been using right now for semaglutide as well as your Trilza. What is the best ratio when you're going to use it in semaglutide? Since very important basic things we need to brush up here. Semaglutide has been widely available for more than 10 years. It has been widely studied for various other conditions. That's one good thing. Apart from your tirzepatide, it's been studied only for the past 4 years. That too for the MASH trials is still happening only for the past 2 to 3 years. So semaglutide, even though the patient beneficial role, the wide acceptance, the cardiometabolic safety, other safety, renal safety has been widely established with the semaglutide rather than much with your tirzepatide and other molecules. So regarding this basic slide, if you are going to see what are the various things, mainly we need to target on 4 major areas. One is lipid peroxidation, mitochondrial dysfunction, your liver damage, all those things, apoptotic pathway activation, all those things to prevent. That's very important area to address. Once the insulin sensitivity is going to get hormone, then your peripheral glucose utilization is going to come down. Almost your gluconeogenesis pathway is going to get shut down, which means the fatty acid oxide, the free fatty acid, if it is going to get circulated in the adipocytes, what is going to happen? It is going to accumulate in the liver, which is predisposing for the patient to land up with evidence of fatty liver. So our area is to target 4 major entity when you are going to address your metabolic associated steatohepatitis. First thing is we need to target which liver fat accumulation drugs to prevent the liver fat to get accumulated. There are a huge list of molecules, among them the GLP-1A receptor agonist is being there, is still considered. And hepatic inflammation, very good as of now, well proven molecule with vitamin E, which has been considered a dose of 800 milligrams per day in prevalence trial. But the risk of prostatic changes and prostatic maintenance are still being there, but that's still proven molecule to be considered by proven match. Apart from that, if the patient is having drugs to use to improve the insulin sensitivity as well as the drugs which be an anti-fibrotic. See, if you are going to look for changes, the status of fibrosis will be F1, F2, F3. See, all these things you can identify by your BCT, which means vibration control, your elastography you can use to identify this picture. So once the patient is going to land with evidence of CAP, what is called as control attention, these are not the fibrosine parameters. You should remember, these things are not non-invasive markers. No need to go for liver biopsy for each and every patient to diagnose with the patient is having evidence of metabolic metabolic and MAS is there or not. So to that kind of patients, you can use so many non-invasive markers like the fibrosis scoring system, your NFS, a non-invasive fibrosis scoring system, your FIFO system, your AST, AAT, platelet, along with age, bilirubin, albumin. These are all the things you can consider. Apart from the APRI, your AST to platelet ratio in Texas, indices can be calculated. And your ELF, what is an ELF? Nothing but your enhanced liver fibrosis panel. In these 3 major things, 3 major enzymes we are going to target. One is your tissue metalloproteinase, apart from that, your hyaluronic acid, your procollagens. These are all the things you need to say. And so many other tests like the fibro test, so many tests are there to prove that the patient is going to land with evidence of steatosis or fibrosis is happening or not. But one simple thing we should not forget. If the steatotic component, if the control attenuation parameter in your fibroscanner value is going to be more than 280, which means the patient is going for severe steatosis. And if the fibrotic component, if it is going to be more than 12, which means the patient landed up with evidence of cirrhotic. So you need to target the fibrotic rate should be less than 6, the CAP value should be less than 240. So that is what the primary indicator to look at. So we need to choose a molecule based upon these parameters. How is it going to work? It's not based upon the one thing which are going to happen. So cardiovascular benefits, respiratory benefits, neurological benefits, renal benefits, all these things you need to address before you're going to target on one molecule. That's very important to choose any patient who is having metabolic liver disease. Because the cause of mortality in any patient with MASLD is not only because of your liver pathology, the main mortality is because of your cardiovascular events. So we need to prevent the major acute coronary events to take on. So that's why we need to look into all these pointers to whom you are going to choose, when you are going to choose, how to choose. All these pointers need to address to look into the picture properly. And basic mechanism of action, briefly, we will be acting on major areas like your brain, pancreas, as well as your liver, and that can indirect benefit as well as in adipocytes. So what's going to happen in your brain? So it is going to control your appetite. So control the appetite, and apart from that, immediately it is going to prolong your gastric emptying. Apart from that, in pancreas, what's going to happen? It is going to include insulin sensitivity. So insulin secretion is going to get augmented along with the glucagon, it is going to come down. In adipocytes, there will be having more of lipolysis. The circulating free fatty acid level is going to come down, which means the liver fat accumulation is definitely going to improve. Apart from that, the glucose production, the gluconeogenesis is going to come from your liver, and your fatty acid accumulation is going to come from your liver. This is all the basic physiology and mechanism of action. Your GLP-1 receptor agonist is semaglutide located there. And before that, there is one more molecule what's called as liraglutide there, but that doesn't show significant response to your fibrosis in the various papers like lean trial and have been tried. But now this molecule, why it has been considered? It is not only improve your NASH, it is also improve your fibrotic component. So MASH as well as your fibrosis, all this seems to be strongly improved along with reasonable weight gain, weight loss will be attained. So that's why this molecule is still being considered well into the field when you're going to look into the target. So mechanism of action has already been discussed, the weight loss, the metabolic benefits, the inflammatory cascade, all these pointers supposed to get come down, and mainly three things we should not forget: the satiety significantly will improve, and along with that the glucagon sensitivity, glucagon levels will definitely go down along with insulin sensitivity is good. So all the molecules we need to improve the lipolytic component along with your insulin sensitivity is supposed to get augmented. That is how the beta oxidation, the dysfunction, all those things is going to take on. That's why you can able to prevent the inflammatory cascade to get settled. And this is again the basic mechanism. So if you're going to look at this graph, so all the things which are shown negative will be an inhibitory effect. So in adipose tissue, the insulin resistance, the adipose dysfunction is going to get prevented because of your semaglutide. Apart from that, the de novo lipogenesis activity, the fatty acid accumulation, all this in the lipotoxicity, oxidative stress related damage will go into control, and all these parameters we should address. So it's having a huge role of beneficial effects in various systems, mainly your GI, pancreas, and renal, GI, pancreas, and hepatic, as well as in neurological parameters. Because in neuro, the satiety will be controlled mainly by your arcuate nucleus and hypothalamus will be getting controlled in that. So this is all the various areas. And see, one important trial, that's what's called as a synergic trial. So in this paper, what they've been looked into there are so many trials have been happening. One is step trial. Step trials mean 1, 2, 3, 4, 5. It is not in the slide, just remember that. Step trial in your semaglutide is mainly used to assess your obesity and weight gain. So in which you will be giving a molecule for a period of time over 2 years, you are going to see whether the patient is responding in the background of diabetes or non-diabetic. That is for step trial. Apart from that, the second trial will be your essence trial, which is mainly in the background of your semaglutide, in which you are going to use your semaglutide molecule at a rate. So slowly you need to titrate. How to use your semaglutide? What is the dose you are going to initiate? Start from maximum dose will be around 2.4 milligrams to 1. Start from 0.5, 1. Every 4 weeks we need to escalate the dose. So how are you going to titrate? That's why very important. So you need to look for AST, ALT, all the parameters, the fibrotic changes, and this molecule over a period of 72 weeks of therapy, there has been shown that the significant response has been attained. But one thing is, it has not been widely approved. It's not in FDA market as of now for evidence of MASH treatment. It's been strongly approved only for the treatment of diabetes. Another thing, not only this molecule, FDA has not been approved for any molecules for the treatment of MASH as of now. Mainly even if it's not been considered well as of now. Only one molecule has been accepted to have a beneficial effect in MASH as well as in your resolution of fibrosis. In these two areas, the one molecule right now global acceptance is resveratrol, which is your THR receptor agonist. Apart from that, no other molecules have been significantly proven, but off-label use, definitely there may be more consideration. So what is the role? If the patient is morbidly obese, they will be having evidence of weight loss will be there, along with the background of diabetes you can consider. If the patient is having biopsy proven, so you need to take a biopsy, you need to look for the picture of MASH. So biopsy proven MASH, this trial has been proven for a period of 72 hours, that patient has significant improvement in MASH as well as no major worsening of fibrosis. But in this paper they have looked into only F1, F2 fibrosis, not F3, F4. So once the patient is landing with early fibrotic changes, that shows a significant response. But advanced fibrosis, for example, if you're coming across your fibrotic score more than 10, that kind of background, the best molecule to choose is your tirzepatide rather than your semaglutide. So in the initial phase of fibrosis, you can use the semaglutide. That's all being the trial, which various papers being shown in there. And this is what the essence trial, which has been concluded with various almost around 72 weeks. The participants are there. This is what they've been shown in the primary endpoints in which the scale hepatic as well as the liver fibrosis. All these things are going to get improved. And this is what they will mention. So histological component has also been improved recently when you are going to use semaglutide. So, and in this paper they have looked into ELF also, enhanced liver fibrosis. If it is going to be more than 9, which means the patient is having significant picture to go for cirrhosis. And this is how they will look for the improvement in various non-invasive tests. At week 72, that showed the decrease in ELF score as well as liver stiffness, fibrosis, your obesity has been decreased. So it showed a significant response once the patient being initiated with semaglutide. So that's how. And apart from that, will be around 10 to 15%, so rather than will be more than 20 to 25%, in which the patient morbid obesity, he deserves tirzepatide. In this, the weight loss will be moderate, so this kind of patients we can give, but gallstone still there's a risk of formation. We need to address that with other molecules and we need a surgical intervention to this kind of patient. And always we need to see muscle mass. Doesn't mean that all the patients are obese will be having good muscle mass. So we need to look for the sarcopenic parameters. All these pointers we need to see, and we need to see the background of obesity with sarcopenia. That's still more difficult challenge to address. So we need to look into the muscle mass, whether it is still preserved, and when you are going to use a semaglutide, there is a possibility even in the background of obesity for the patient to go for evidence of your loss of muscle mass. That has to be treated properly. And so we need to practical tips like don't eat too much, avoid fried foods, junk foods, and carbohydrate-based diet, and your fatty foods, high fatty meals, shorten small duration, frequent small meals, early meals, and your lifestyle modification. All these things to be considered in your going to do. But very importantly, we need to elevate your anxiety and all these parameters to address the diet, low fat, and high sweetened beverages, carbohydrate dense load are supposed to be get controlled when you are going to look. Very importantly, all this incretin analog, incretin, why it has been considered mainly acting in your L cells in the intestine. And there is a parameter what's called as the C cells in your thyroid. So it's literally C cells. In case if the patient is going to have a multiple endocrine neoplasia type 2 or in the background of your any medullary carcinoma of thyroid, in which the C cells will be predominantly low. But type 1 there's no major role because apart from parathyroid and other organs will be in type 1. But in type 2 men we need to be very conscious. But there are some papers to look into that. But even though if the patient is having type 2 men along with your medullary carcinoma or if there is having previous hypersensitivity, these are all the contraindications. Still no major paper role to get documented that you are going to consider. And warning signs as already discussed, hyperglycemia, GI, thyroid, GB, cardiac renal injury, and renal injury, hepatic injury, and apart from the cardiovascular stability, all these things are still being proven. And moreover, very rare patient with evidence of QTc prolongation. Some papers are being there looked into that, but there is no major role apart from except. So very importantly, this condition, there is a paper to report that this is not arthritic, optic neuropathy involved. One means is anti-ischemic optic neuropathy, not arthritic phase. So what is going to happen once the patient is going to use semaglutide for a duration at the rate of almost 2.4 million for a longer duration? There is like few percent papers are there to report that adverse event to happen, but it is less than 0.5% when compared to the placebo. So no need to worry much about this. These things we need to be very cautious. But apart from that, what are the various risk factors if the patient has dyslipidemia, hypertension, the same picture like your vascular affliction, this might be a triggering factor in your hypertension, has to be well controlled, all these things. But there might be association to look into your LAION when you're going to use your semaglutide. And new molecules like your twin creatine, nothing but your GLP-1 along with your GIP-2, like your tirzepatide. Why is this molecule? Tirzepatide morbidly obese, biopsy proven match. So you can definitely consider. If you want to bring the BMI rapidly down, which means less than, if you want to improve the weight loss more than 20 to 25%, means you need to consider tirzepatide. And if you want a good peripheral utilization of insulin as well as the glucose and all this process to prevent major hypoglycemic events, you can consider tirzepatide molecule, which is a twin creatine. What is the major difference? Means the problem is it is not a structural homology. When compared to semaglutide, we have structural homology. It will be almost in a natural neutral environment, like your original molecule, your semaglutide. It is almost around 94%. There are two chains. One is aliphatic chain. One is apart from the one. Another component will be the albumin. The half-life will be your semaglutide will be around 7 days, or this tirzepatide will be in the range of 5 days. That is why weekly regimen, supplement based regimen, they have been trying this kind of molecule. But when you are going to use tirzepatide morbidly obese, diabetic, NASH, definitely you can consider in the background of or no major worsening of liver parameters like your cirrhotic and other complications. At that point, If the fibrotic score, if it is going to be more than F2, F3 fibrosis, that kind of patient we can consider. This synergy trial, which has been shown over a period of 58 weeks of therapy, when you are going to use this molecule, that shows significant response to your fibrosis. The value has come down more than F1, F3 to F1, F2 has been improved, and the steatohepatite is also improved to this kind of patient. That's what the study design has been schematically represented. So what is the major difference between these two molecules? The study duration will be very less with the tirzepatide when compared to semaglutide, and always the homology succinyl differentiation will be there. And moreover, the tirzepatide is a synthetic derivative. Apart from the cardiovascular safety, renal safety, hepatic safety, they still believe more and more papers to look into that. There are some papers in which they will look into the QTc prolongation with your tirzepatide being there, but still not been fully confirmed, and we need years to look for this kind of thing that is happening or not. The major thing, the beneficial role with the cardiovascular, other significant weight loss and all those things, even though not much of significant potential role, but if the patient is having F1, F2 fibrosis, definitely we can consider the semaglutide when compared to your tirzepatide. And this is what the basic things already been discussed with various vascular events. The proven trial will be with the semaglutide when compared to tirzepatide, renal, heart, liver, non-diabetic. And apart from the other molecule now that we've been used for years, which means a dual agonist, PPAR, alpha as well as gamma. There is one more agonist called elafibranor, which means the PPAR alpha, delta as well as gamma. What is the difference? This patient you can use for lean NASH. So if the BMI is going to be less than 23, your saroglitazole definitely, because atherogenic dyslipidemia, your diabetic dyslipidemia, your saroglitazole will be a very potential. But the problem is weight loss. No major weight loss when you are going to use a saroglitazole, no major role. In diabetic prevention, no major role. So this is for diabetic we can consider, but strong augmentation will not be there when you are going to use a saroglitazole. So in the background of lean NASH, with the biopsy proven, all these things with a major complication, definitely we can consider saroglitazole as still proven molecule, and you are going to use a dual PPAR alpha as well as your gamma agonist when you are going to. So it's alpha and gamma. Why? The alpha will be acting in the fatty acid pathway. The gamma will be acting mainly to improve your insulin sensitivity. And saroglitazole, various strains are there, mainly weight neutral, biochemical, Indian context, well accepted histological improvement. Another molecule is your resmetirom, 80 milligrams and 100 milligrams, 2 doses, maestro trial being proven, globally well accepted molecule, but the problem is the histological parameters, fibrotic changes, even though it's been accepted, but not very significant response when compared to your tirzepatide and other molecules. In the background of morbid obesity, there is still no major value, but that is shown, the imaging landscape showed that the resmetirom still being well proven molecule. But when compared to this, the major three trials, weight loss, not major benefit with the saroglitazole and your resmetirom, but semaglutide definitely will be a significant role. And almost mass resolution will be 60% more, and resmetirom around 20% to 50%, saroglitazole moderate efficacy when compared to other molecules. And various guidelines also accepted that your GLP-1 definitely can be considered if the patient is having MASH along with diabetic, along with other parameters. And various trials are there. I don't want to discuss much about that. Very importantly, combination therapy. When you want to use a combination, if the patient is having obesity, MASH, along with evidence of your dyslipidemia in the background of your fibrotic high score, to that kind of patient you can use semaglutide as well as your resmetirom. That's combination molecules with your incretin along with your resmetirom can be considered with your THR receptor agonist. These things can be considered. So before concluding, very importantly, lifestyle modification is a key pivotal role which is going to take on. Apart from that, proper assessment, early diagnostic markers we should not miss when you are going to look for infertility. Metabolic syndromes should be significantly addressed. When you are going to choose a molecule, see through that whether the patient, what are the various comorbidities the patient is having. And very importantly, you should address that to whom we are supposed to use, where to use, when to use, how to use. This is how we need to see whether the patient is going to respond to the therapy or not. There is a mandate to rest. Thanking all of the patient.